Committee meets this morning to discuss mental health care in America. And this issue certainly ought to bring Democrats and Republicans together, starting with a single, clear lodestar. That lodestar is every American must have mental health care when they need it. And the shameful reality is the United States doesn't come close to meeting that bar today. Multiple federal laws say that mental health care is supposed to be on a level playing field with physical health care. In practice, however, the system still reflects the dangerous, outdated stigma against recognizing and treating mental illness, and that's why millions of Americans are now falling between the cracks. For someone with a mental illness, it can often be nearly impossible to find a provider who can meet your needs or one who accepts insurance, particularly in rural communities or communities of color. Insurance claims often get denied or cut off too quickly, particularly for those experiencing homelessness. The outcome of a mental health crisis is often incarceration instead of treatment. Prior to the pandemic, 1 in 5 Americans was living with a mental illness. All the evidence suggests that the pandemic is adding to that crisis. The proportion of Americans reporting symptoms of anxiety or depression has nearly quadrupled. On Friday, the Centers for Disease Control and Prevention released a new report finding that over the last year, suicide attempts among teenage girls were up more than 50%. Meanwhile, a study that the Governmental Accountability Office conducted at our request found that many provider offices closed or cut staff during the pandemic, and then too many patients were turned away. So there is a lot for this committee to work on a bipartisan basis. A few key challenges. First, the country clearly needs a larger, talented mental health workforce. There simply aren't enough providers, whether it's psychiatrists or therapists or staff in inpatient facilities. For example, due to a major staffing shortage, the psychiatric hospital in my home state in Salem, Oregon, is currently being staffed by members of the Oregon National Guard. That's in a state capital where there are people and resources to focus on the issue. Many other communities have it far worse. More than 1 in 3 Americans lives in an area with a serious shortage of mental health care professionals. Second, insurance companies must not be allowed to cut corners when it comes to mental health coverage. I hear about this issue constantly at town hall meetings. People describe having their claims denied. In other cases, insurance only covers a portion of the treatment that people need. Furthermore, it doesn't make any sense to leave somebody experiencing a true mental health crisis waiting for a green light from an insurance company before they can get treated. Third, clearly the committee has a big challenge to address racial inequities in mental health care. Black and Latino Americans are roughly half as likely as white Americans to receive treatment for mental illness. Suicide rates are much higher among Black kids. There aren't enough Black, Latino, and Native American mental health providers. So this is a question of equity and a long way to go. Finally, the committee ought to build on recent progress. For example, early in the pandemic, this committee led the fight to get Medicare to cover mental health services via telehealth. In December, the Congress made that permanent. I believe that's going to be a game changer, particularly for seniors who live in rural areas, and it's going to work in traditional Medicare as well. And my colleagues all know that so many of our reforms have helped particularly with Medicare Advantage and other programs where there's coordinated care. We've got to make sure traditional Medicare is afforded these benefits as well. Finally, Senator Stabenow has been a champion of mental health care, my seatmate, and I have watched for years as she has led the effort to bring certified community behavioral centers, a program that she battled for and created to American communities. These clinics are up and running now in 40 states, including Oregon. It's an approach that works and meets major needs. So I believe the Congress ought to look at ways to build on the success that my colleague has led. And we should also note, again, the bipartisan roots, because I can't tell senators how often I have seen Senator Stabenow and Senator Blunt huddled in intense discussions about how they're going to expand this. Finally, the Congress also passed a big down payment for a pioneering new approach on mental health services and law enforcement. It's called the CAHOOTS program. Originally comes from Eugene, Oregon, where I went to law school. But it's expanding now all over the country. And essentially, what happens with this approach, you have a 911 call with somebody experiencing a mental health crisis. And at that point, the mental health care professionals and law enforcement in these communities have essentially teamed up and figured out a way to actually meet the need of the patient and the community. So in many instances, these joint efforts with mental health professionals and law enforcement, a team, a coalition approach. And in Oregon, I've talked to the police officials in Eugene, mental health professionals in Eugene. Very often the response, and they both have kind of worked up a system to do the right thing, is to use mental health professionals rather than law enforcement. And law enforcement, to their credit, is saying that they want to do that, and often the mental health professionals are the right response. The American Rescue Plan included a $1 billion payment to help states build on their own programs, and I think we ought to look at what else ought to be done. Last point I made, and Dr. Cassidy is here, and he has great expertise in this area. Colleagues, this is an enormous challenge, and I think it is a natural for Democratic and Republican members of this committee to step up and shape a major response that we can take to the full Senate. I look forward to working with all my colleagues. Senator Crapo.
Thank you very much, Mr. Chairman. I appreciate your holding this hearing, and I agree with your comments that this is an issue that deeply needs good solutions and on which we can build strong bipartisan solutions that work. And I look forward to working with you, Senator Stabenow, and all the others that you've mentioned on these issues. Ensuring access to high-quality mental health services has been and must continue to be a priority. Far too often, individuals with mental health, addiction, or substance abuse disorders find themselves isolated from their communities and separated from their providers. While Congress has taken decisive steps to address addiction, bolster behavioral health care, and curb substance abuse disorders, challenges remain. This committee has the ability to turn the tide. We can begin by empowering states to craft innovative, targeted solutions. Medicaid functions most effectively when states have the flexibilities they need to address patients' unique care needs and adapt to unforeseen circumstances. As the nation's largest payer of mental health and substance abuse disorder services, Medicaid must support rather than subvert state efforts to serve communities in need. Unfortunately, the COVID-19 pandemic has highlighted and exacerbated the mental and behavioral health challenges we continue to confront. Loss of loved ones, increased isolation, and delayed treatment prompted a spike in anxiety, depression, and other debilitating conditions. While many are returning to their pre-pandemic lives, we should not be content to allow our mental health care delivery system to revert to its pre-pandemic ways. Whether for rural communities, urban areas, or tribes, telehealth has undoubtedly increased access to care. Through emergency flexibilities and permanent legislation authored by this committee late last year, we've taken crucial first steps toward modernizing telehealth coverage. I look forward to working with you, Mr. Chairman, and the other members of this committee to build on those efforts in months ahead. Further, by partnering with state and local leaders, we can spur care coordination, strengthen the mental health workforce, and drive value through delivery system reforms. While there is no silver bullet here, I'm confident we can tackle all of these challenges while upholding core principles of fiscal responsibility and program integrity. Before concluding, it bears emphasizing that we must continue to make progress in improving understanding of mental health so that people in need are not afraid or ashamed to seek treatment. We cannot discount the impact of stigma on preventing those in need of treatment from receiving care. I look forward to hearing our witnesses' testimony today and appreciate each of you coming here to share your expertise and ideas about how we can achieve these objectives. Thank you very much.
Thank you, Senator Crapo. We've got 4 terrific witnesses. The one who will testify first, and I think we'll do the introductions because colleagues are juggling a lot this morning, is Dr. Miller, and Senator Bennett will give the introduction for Dr. Miller. We'll introduce all our witnesses, and then we'll hear their testimony. Senator Bennett.
Thank you, Mr. Chairman, and I'd like to thank you and Senator Wyden for holding this important hearing on mental health. From the perspective of Colorado, it could not come soon enough. In my calls with parents and teachers over the past year, the number one issue has been mental health. And over the years, the person my office has turned to for advice on these issues was Dr. Benjamin Miller, one of our witnesses today. Dr. Miller is one of the country's foremost experts on mental health. Today, he serves as the Chief Strategy Officer for Wellbeing Trust, a national foundation dedicated to advancing a more holistic approach to the health of every American. In his early training, which included a doctorate from Spalding University and postdoctoral roles at the University of Colorado and the University of Massachusetts, Dr. Miller saw firsthand how America's inattention to mental health inflicts a terrible cost on our society, from our schools to our foster care, health care, and criminal justice systems. Dr. Miller hasn't just studied these issues in the academy, he's worked on them firsthand in our communities. He's helped emotionally disturbed children make it through school, cancer patients cope with a difficult diagnosis, and prisoners plan their reintegration into society. He's also trained physicians to better handle their patients' mental health. These issues are not abstractions for him. They're real people whose lives have directly benefited from greater attention to their mental health. I know Dr. Miller from his time at the University of Colorado, where he led the university's Health Policy Center for 6 years and was an invaluable resource to my team. During his time at the center, Dr. Miller led a breakthrough project demonstrating the cost savings of integrating mental health with primary care. That project saved over $1 million for Medicare and Medicaid beneficiaries in Colorado by significantly reducing hospitalizations and other medical needs down the road. As healthcare costs in this country continue to rise, I think the committee has a lot to learn from Dr. Miller's experience and expertise. I could spend the next 5 minutes listing the numerous awards and appointments he's earned over the years, but let me instead conclude by thanking Dr. Miller for joining us today, especially since he's supposed to be on vacation right now with his wife and 2 daughters. We're grateful for Dr. Miller's time and for your service to Colorado and the country. Thank you, Mr. Chairman.
Thank you, Senator Bennett. The next witness will be from Oregon. Shante Jett is the Executive Director at Wallowa Valley Center for Wellness in Enterprise, Oregon. It is a small community. I've been there often in rural Eastern Oregon, and as is the case with so many people I have the honor to represent, she is the bionic woman. She is basically everywhere, colleagues. She has worked in the Wallowa River House, a residential treatment facility for folks in Oregon with severe and persistent mental illness. She's been an outpatient mental health clinician. She's a pillar of the community. I remember recently having, we call sessions in schools called Listening to the Future. Shante was there. And she holds a master's degree in psychology with a child, couple, and family emphasis, a bachelor's degree in business administration. And she also worked with children in inpatient psychiatric unit at Children's Hospital. So Shante, thank you for making the long journey from rural Oregon. We're so glad you're here, and I know the committee is going to appreciate hearing from you. Next, we'll have Dr. Durham, and a great advocate for patients and those facing health challenges. Senator Elizabeth Warren is, I believe, online, and she's going to introduce Dr. Durham. Senator Warren, you out there in cyberspace?
I am. Thank you very much, Chairman Wyden, Ranking Member Crapo. Thank you for having this hearing today. I have the privilege of introducing Dr. Michelle Durham of Massachusetts. She's agreed to speak to the committee today about the importance of expanding access to mental health services all across our country. Dr. Durham currently works as a pediatric and adult psychiatrist at Boston Medical Center. Now, BMC is the largest safety net hospital in New England, and it is also an academic medical center that's located in the heart of Boston. It is an amazing place. Most of BMC's patients are low income or from underserved populations. About half are covered by Medicaid. Throughout the COVID-19 pandemic, providers at Boston Medical Center, including Dr. Durham, have gone above and beyond to get patients the healthcare services that they need. Our communities owe a great debt to the folks at BMC. At BMC, Dr. Durham serves as the Vice Chair of Education in the Department of Psychiatry. She also has a joint appointment as Assistant Professor of Psychiatry at Boston University School of Medicine, and she runs the training program for BMC's General Psychiatry Residency Program. As you say, Chair Wyden, this is another woman who is everywhere. Throughout her career, Dr. Durham has been a tireless advocate of health equity and mental health, and she is the Associate Director of BMC's local Center for Mental Health Disparities. She also co-leads the Team Up initiative at BMC, which works to expand pediatric mental health care at federally qualified community health centers. Dr. Durham was an expert on mental health long before the coronavirus, and she also worked on the front lines of the pandemic. Her testimony today will offer significant insight into how Congress should be considering reforming and improving our mental health system to both build back from the pandemic and to fix problems that existed long before that pandemic hit. So, Dr. Durham, I am deeply grateful for the work you do for patients, for students, and for the people of the Commonwealth of Massachusetts. I look forward to having a great discussion today. Thank you, Mr. Chairman.
Thank you very much, Senator Warren, and thanks for your help in assisting us in making sure Dr. Durham could be with us today. Our last witness will be Tom Betlach, a partner at Spire Healthcare Strategies prior to joining Spire. Mr. Betlach served the state of Arizona for 27 years with 5 different governors and 3 different cabinet positions. For 10 years, he served as director of the Arizona Healthcare Cost Containment System. That is, as I understand it, Arizona's Medicaid program. He's got a master's in public administration from the University of Arizona and a Bachelor of Arts in political science from the University of Wisconsin. So we're very glad you're here as well. Let's begin, and we'll start with Dr. Miller.
Well, thank you for that wonderful introduction, Senator Bennett. Chairman Wyden, Ranking Member Crapo, and members of the committee. My name is Dr. Benjamin F. Miller, and I'm the Chief Strategy Officer for Wellbeing Trust, a national foundation started in 2016 through a gift by the Providence Health System that is focused on advancing the mental, social, and spiritual health of the nation. I'm a clinical psychologist by training and have spent most of my adult life pursuing strategies that can advance mental health to a place of priority within our society. This goal has guided much of my work during my time as the founding director of the University of Colorado's Farley Health Policy Center and continuing today in my capacity as an adjunct professor at Stanford School of Medicine and at Wellbeing Trust. It is an honor to be able to speak to you today about an issue that every American is experiencing, an issue that we need to aggressively pursue and which COVID-19 has all but exacerbated, especially among communities of color and other marginalized people, our mental health. Several government reports highlight how broken our mental health system is. The 2020 DoD Inspector General report found that over 50% of service members and their families who needed mental health care did not receive it. SAMHSA found that over 56% of adults with mental illness did not receive any treatment in the past year, nor did 35% of those with serious mental illness. And a recent GAO report highlighted a multitude of issues at multiple levels for mental health, including ongoing challenges with health insurance, enforcing laws like mental health parity, and finding the right clinician who can help. In one survey, almost 30% of people reported not seeking care because they did not know where to go. The need to solve for these and other existing problems is real and immediate. Clear pathways do not exist for people seeking mental health care. There are not obvious doors to enter, and we have no system that routinely is able to identify and treat people in a timely manner. This is perhaps our greatest challenge as we emerge from the devastating COVID-19 pandemic. With broad majorities in both parties now understanding the importance of addressing mental health, I believe it is time to enact immediate fixes for people in need, as well as to begin to lay the foundation for a reimagined mental health system, a mental health system that is grounded in community and an integral part of our broader healthcare infrastructure. There are three key priorities I believe this committee should consider as it pursues both short and long-term reforms for mental health. First and foremost, we need to bring mental health care to where people are. This includes schools and even our workplaces, but to most immediately meet this moment, the best place to start is primary care, the largest platform of healthcare delivery. In one poll, 70% of adults agreed that it would be more convenient if their mental health and substance use services were integrated into their primary care doctor's office. To do this, we must create more global and flexible funding mechanisms for primary care practices who are working to integrate mental health. Our payment mechanisms often reinforce a siloed delivery model, and this must change. By first using existing payment structures like those found in Medicaid managed care organizations, Medicare accountable care organizations, and Medicare Advantage plans to expand mental health integration work, primary care practices would have the flexible financial resources to onboard mental health clinicians as a part of their integrated team. Second, we must reconsider the design and capabilities of our workforce. Demand for care has far outpaced the supply of mental health clinicians, and it is inconceivable to rely upon clinician recruitment strategies alone to meet our ever-growing need. There are two things we can do simultaneously to address this workforce issue. First, we can map out mental health utilization gaps to better determine where services are needed and for whom. Without this, we run the risk of widening disparities or putting money into places or programs that people are not using for their mental health. Second, we invest in our community workforce, those like peer support specialists, community health workers, or more broadly, lay people in our communities. We train them in mental health skills to help become the first line of mental health support, complementing our clinical enterprise and enhancing the overall capacity for communities to address mental health needs. Finally, we must modernize and connect our federal programs and systems to collaboratively solve for common mental health problems. I realize it is hard to ask committees to work across jurisdictional boundaries, but so many aspects of our mental health need to be understood together and implemented together at both the state and community level. Because there are multiple agencies, funding streams, and programs that support mental health, performing a landscape analysis can create a strategy for synergistic efficiencies by breaking down silos across federal agencies and departments and allowing for a more cohesive plan for mental health. In closing, I thank this committee again for holding a hearing on mental health. This is our moment to be bold in what we can do to boost our nation's mental health and ultimately save lives. Thank you, Chairman.
Thank you very much, Mr. Miller. Okay, I think next we'll go to Dr. Miller has gotten us off to a strong start, and now we'll be with Ms. Jett.
Good morning, Chairman Wyden, Ranking Member Crapo, and members of the Senate Finance Committee. Thank you for the opportunity to discuss policy solutions to address both the mental health and substance use crisis impacting the United States, and in particular, rural and frontier areas of our nation. My name is Shanti Jett, and I am the Executive Director for Wallowa Valley Central Wellness, which provides community-based mental health and substance use treatment services in the most remote region of our great state of Oregon. We represent a truly frontier area of our nation, where the cows outnumber the people, and the closest airport is Boise, Idaho, nearly 4 hours away. We are literally at the end of the road where everyone knows everyone, which unfortunately contributes to the stigma and lack of access for people seeking treatment services. I am here to tell you that the Certified Community Behavioral Health Clinic model has truly made a difference in our frontier community. I hope every state in the near future has an opportunity to use the resources this model has made available to us to meet the specific needs of our community. The state of Oregon participates in a 10-state demonstration of excellence in mental health and addictions treatment act that this community helped to establish in 2014 through the bipartisan leadership of Senators Stabenow and Blunt. The Center for Wellness is one of 12 CCBHCs that operate within our state. We provide high-quality, integrated, community-based mental health and substance use services to individuals while also screening for possible comorbid conditions like heart disease, diabetes, HIV, and AIDS. Among the most important services that CCBHCs provide, both in Oregon and nationwide, are immediate access to medication-assisted treatment services for substance use and 24-hour psychiatric services. Please permit me to provide some very brief context of CCBHCs within rural and frontier counties in the state of Oregon. According to the Oregon Health Authority, our state reports higher rates of mental health conditions, including severe and persistent mental illness and suicidal ideation. The COVID-19 pandemic has only exacerbated an ongoing mental health and substance use crisis in rural Oregon. OHA also details a lack of access to mental health and substance use care, especially in frontier communities. To give you a sense, there is no stoplight within a 76-mile radius of Wallowa County. The OHA reports an average wait time of as much as 6 months statewide due to a lack of providers. However, we are the lucky ones because the CCBHC model helped create an internal reorganization of service delivery, which resulted in same-day access to care. Prior to becoming a CCBHC, the Center for Wellness was heavily reliant upon grants. Grant funding is crucially important, but it carries limitations. Grants typically end every 2 to 3 years. They all have different reporting requirements and different program specifications, which ultimately results in more time spent filling out paperwork rather than treating our patients. By contrast, the CCBHC prospective payment system provides us to do 3 major things. First, the Center for Wellness contracts with more skilled clinicians, including psychiatrists and medical professionals, to prescribe medication-assisted treatment for patients with opioid use disorder. This directly results in decreased wait times and reduced emergency department visits. Secondly, the CCBHC program is designed to expand access to underserved populations. In our community, the CCBHC really opened the door for mental health care to veterans. According to our local VSO in our county, there are at least 1,000 community members who have donned the uniform out of 7,000 residents. Becoming a CCBHC has allowed us to increase our services to 23 veterans in our community. This may not seem significant to you, but it's a 300% increase in services. Thirdly, consistent CCBHC resources are a fundamental driver of integrated care. In Oregon, the CCBHC demonstration financing has made it possible to integrate with a local federally qualified health center, allowing primary care, dental, and behavioral health services all under the same roof. We also share a single electronic health record to permit immediate care coordination. Patients often tell me that it is such a relief to not have to retell their story with every provider they meet. We are lucky that we have a great neighbor in the state of Idaho when we have no acute psychiatric beds available. This component of care coordination and partnership with primary care and hospitals, even across state lines, is imperative because patients with severe mental illness and substance use challenges have shockingly high rates of medical conditions. The CCBHC model allows us to have these partnerships and get patients the services they deserve in a timely manner. In closing, I strongly believe that this model represents the future of community-based mental health and substance use treatment in the United States. This is why I'm asking you to make this model available to every state nationwide. As a nation, we can do better than first treating mental health and substance use in hospitals, homeless shelters, and our county jails. Investing in CCBHCs is streamlining services in efficient ways that drive costs down over the entire continuum of care. Despite being from a tiny frontier community at the end of the road in northeastern Oregon, I hope you can see that CCBHCs make an enormous impact. Again, thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you very much, Ms. Jett, and you make Oregonians proud this morning. I would also note you're mentioning the Idaho-Oregon Alliance. Senator Crapo's ears perked up when he heard that. And on all these incredible efforts, we have talked about a lot of them. And I just want you to know that it is a tremendous honor to really be your wingman in some of these causes, because we got a lot of work to do, and you've laid out a very powerful case about some of the most important elements. So thank you, and thank you for making the long trip.
Thank you.
Okay, next will be Dr. Durham.
Thank you, Chairman Wyden, Ranking Member Crapo, and distinguished members of the Senate Committee on Finance for holding this hearing and providing me with the opportunity to speak today about the state of mental health care system in America, where it's working, where it falls short, and how the federal government can play a role in helping to fill the gaps. Thank you, Senator Warren, for the kind introduction. Boston Medical Center is an academic medical center and the largest safety net hospital in New England. The patients we serve are predominantly low income, with approximately half of our patients covered by Medicaid or the Children's Health Insurance Program, the highest percentage of any acute care hospital in Massachusetts, and one of the highest in the country. Mental illnesses are all too common among the patients BMC treats in our emergency department and across our continuum of mental health care services, which include outpatient integrated mental health care within our pediatric and adult primary care clinics and at local community health center partners. A mental health urgent care clinic, a crisis stabilization unit, and our Boston Emergency Services team provides community-based evaluations and a jail diversion program. At present, BMC does not own or operate a locked inpatient psychiatric unit. The patients we see at BMC who present with mental illness frequently have co-occurring substance use disorders, homelessness, malnutrition, and other health-related social needs linked to poverty. The current COVID-19 pandemic, structural racism, and economic crisis has further exacerbated the mental illness and trauma experienced by our patients. In my 10 years at BMC, I've never seen our mental health care services stretch so far beyond their capacity as they are now. Just the other day, we had 25 patients in our psychiatric emergency department, more than triple its capacity, presenting with much higher level of acuity, some waiting for evaluation, and others boarding awaiting placement in an inpatient psychiatric unit. It is widely understood and well documented that America has a dearth of licensed mental health professionals in general, and that particular areas of the country, largely rural and outside of the Northeast, are disproportionately impacted. Even where I practice in Boston, which has one of the highest number of child and adolescent psychiatrists per capita in the country, the capacity is insufficient to meet the mental health needs of the community. Increased Medicare graduate medical education funding for psychiatry residency slots can help increase the physician workforce. Increased funding for loan forgiveness programs for those who work in underserved areas can help alleviate the over $250,000 of debt that the average medical student has accumulated by the time their residency education is completed. The need to pay off medical school loan burden is also likely to cause physicians to pursue practice in more affluent areas, adversely impacting access to care for the low-income populations. Beyond the shortage of providers, the mental health workforce is not diverse. For instance, only 2% of psychiatrists identify as Black and not representative or reflective of the U.S. population. In order to address this, we must understand that the issue at its root is a pipeline issue that requires holistic solutions. Just as we say in medicine that a person's zip code is more influential than their genetic code in determining life trajectory and long-term health, where a person lives, the color of their skin, and language they speak is highly determinative of the quality of education and resources available, the level of exposure to the mental health field, and the stigma associated with mental illness. In terms of access to mental health services, COVID-19 led to an accelerated adoption of telemedicine. At peak, over 90% of our outpatient psychiatric visits were conducted via telehealth, which enabled BMC to maintain and exceed our pre-pandemic volume of service. That said, while telehealth is an important tool for ensuring patient access to mental health care, it does not work for everyone due to digital inequities that exist related to internet access and digital literacy, especially among low-income communities. The social determinants of mental health and structural vulnerabilities inherently involved with treating low-income patients require more dedicated time with patients to provide appropriate care. Insufficient Medicaid reimbursement acts as a deterrent for providers to see Medicaid patients, producing a cascade effect in which the more oppressed, marginalized populations have limited to no access to mental health professionals. At BMC, we've developed some innovative models to improve access to mental health services, which are ripe for replication and scaling. Transforming and expanding access to mental health care in urban pediatrics, otherwise known as Team Up for Children, a pediatric integrated model in federally qualified health centers in Massachusetts, builds capacity of health centers to deliver high-quality, evidence-informed care to children and families. The model includes behavioral health clinicians, community health workers working with pediatric primary care providers to provide timely mental health treatment. The Wellness and Recovery After Psychosis program is tailored for people experiencing psychotic symptoms using a team-based approach and providing individual, group, and family therapy, medication management, case management, and peer support. In addition, Massachusetts is home to some other models in which BMC participates. The Massachusetts Child Psychiatry Access Program, known as MCPAP, improves access to treatment for children with behavioral health needs and their families by making child psychiatry services accessible to primary care providers across Massachusetts via remote consultation and education. This model has been expanded to other states such as Connecticut, where I completed my fellowship. The Metro Boston Recovery Learning Community offers peer-to-peer services for people in recovery from mental health and or substance use issues through peer support, advocacy, and career coaching. We are at a pivotal time in our country. Over a year into the COVID-19 pandemic, every person's mental well-being has been impacted in some way. The need for a more robust mental health care system has never been more clear or pronounced. Treatment for mental health issues should be accessible, no matter who you are, where you live, or your ability to pay. Appropriate investment along the care continuum and for the mental health workforce can improve access to care and retention and recruitment of mental health professionals. The time is now to invest in a 21st century mental health care system in America. Thank you for your time, and I look forward to the discussion.
Very good, Dr. Durham. I know that we'll have questions for you in just a couple of minutes. Mr. Betlatch, welcome.
Thank you, Chairman Wyden, Ranking Member Crapo, and members of the Senate Finance Committee. Thank you for the opportunity to testify today on policy solutions for addressing mental health. I had the privilege of serving as the Arizona Medicaid Director for almost a decade, and for a portion of that time as the Mental Health Commissioner. Medicaid serves over 70 million members, offering comprehensive mental health benefits to some of the country's most complex populations. As you formulate health policy options, state Medicaid programs should be a critical component of the discussion. Understanding the system and the forces prevailing on it should be at the core of the discussion. The last year brought to light the extreme fragmentation of our healthcare delivery system at all levels. Our policy and program structures are in silos. Funding streams to support these populations follow those siloed program and policy structures. Providers gravitate towards these funding streams, creating more complexity at the point of care, and the very beneficiary the system is designed to serve is forced to navigate the maze we've created. Today's environment has challenges, but states and Medicaid programs now have access to considerable federal investments to address these challenges. Examples include the 5% set aside from the Mental Health Block Grant used for crisis, 85% enhanced match in Medicaid for the CAHOOTS program, 10% increased federal funding for home and community-based services for the Rehab Option Services, and the expansion of certified community behavioral health clinics. In February 2021, the National Association of Medicaid Directors published Medicaid Forward, Behavioral Health, outlining a series of strategies Medicaid programs are pursuing to advance mental health services for members. The strategies varied based on the unique population served by Medicaid. This report highlighted initiatives such as expanding access and improving timeliness to care, integrating physical health and behavioral health, and expanding access for the full continuum of care, including crisis services. Further, a March 2021 Bipartisan Policy Council report concluded that integrating primary and behavioral health care is necessary and would ensure that individuals with behavioral health conditions and comorbid physical health problems receive high-quality access to care. Arizona provides a strong example of this. In 2011, we pursued a multi-year strategy to better integrate services for individuals with serious mental illness. This strategy was focused on driving integration at 3 levels: policy integration, payer integration, provider integration. In 2018, Mercer Consulting conducted an analysis of the integration efforts. Their final report for individuals with serious mental illness found that all measures of ambulatory care, preventative care, and chronic disease management demonstrated improvement. Just as important, all indicators of patient experience improved, with 5 of 11 measures exhibiting double-digit increases. Another opportunity highlighted by NAMD is to strengthen crisis systems. This issue is front and center with the implementation of 988. SAMHSA provided extensive thought leadership with the development of the Crisis Now model to serve anyone, anywhere, at any time. The Crisis Now model is based on 3 critical components: call center capability, 24/7 community mobile response teams, 23-hour crisis receiving and stabilization units. In Arizona, this system has been developed over the past 20 years and serves all Arizonans. The financing for this system comes from creatively braiding multiple funding streams while leveraging Medicaid for support. While we have seen improvement, there is clearly much more to do. To that end, Congress and the executive branch need to develop and implement strategies holistically by ensuring Medicaid and behavioral health collaborate and partner in a meaningful manner. On several occasions, Congress has leveraged the mental health expertise that lives in SAMHSA to advance policy initiatives. However, there does not appear to be sufficient expectations established by Congress that these important planning and investment dollars are to be linked to the Medicaid program. Unfortunately, the dollars often get siloed and the opportunity is suboptimal. At the end of the day, Medicaid beneficiaries may or may not benefit from these forward-looking investments. Congress should provide more flexibility with block grant funds for states to address social determinants of health as states look at ways to support these investments. Congress should look at legislation to establish parity between Medicare and Medicaid. Where Medicaid has led the way in developing paraprofessional staff, such as peer support services, and systems to support broader populations like crisis, Medicare should follow. Congress should continue to provide financial incentives for states to modernize mental health infrastructure, like the investments made in CAHOOTS and CCBHCs. Congress should continue to evaluate the impact of the IMD 16-bed limit. While there have been efforts made to allow for some payments in select instances, some states have not been able to avail themselves of these opportunities. Congress should rectify the fact that behavioral health providers were excluded from the Electronic Health Record Incentive Program provided through the HITECH Act. And finally, as was mentioned by Dr. Durham, Congress should revisit the GME funding that's made available through Medicare and the 1996 caps. We're at a critical moment in time to advance the delivery of mental health services, not only within Medicaid, but for our entire country. Thank you for your time and interest in these topics.
Thank you very much, Mr. Betlach. We'll start with you, Ms. Jett. I think what you and your colleagues are saying is you can't expand mental health care without expanding a trained workforce. And this is especially true in rural areas, and your eloquent words, I believe, spoke for a lot of providers from rural areas. And it seems to me you've got a big challenge filling some key slots. Licensed clinical social workers who serve Medicare and Medicaid patients, nurses who do so many things well, starting with health screens, and recovering patients who play a key role in terms of peer support. And listening to you over the years, you've convinced me these professionals are essentially the glue to holding a mental health system together. Now, I'd like to get your thoughts with respect to the workforce, and particularly on the question of having enough people and then preventing burnout, because my understanding is that the pandemic just made things a lot more treacherous for so many professionals who just want to step up and help people. Deaths from opioids are 30% higher than last year. The number of emergency department visits for suicide and drug overdoses are up more than 25%, 3 to 4 times as many people identifying as facing depression today than before the pandemic. Why don't you tell the committee, because I've heard you speak to this in the past, it was always a challenge before the pandemic. Tell us what you think is really happening now with how the pandemic has made it much harder for you and your colleagues to do the terrific advocacy you do.
Sure, I'm happy to speak to that. Crisis burnout is at an all-time high. Every single one of our crisis clinicians, well, clinicians in general that we hire have to take a crisis rotation. The crisis numbers since the pandemic started has tripled. And the acuity level of those crises has gone from a very simple, I have a lot of anxiety, my cat is stuck in a tree for the past 2 days, I'm not sure what to do, I'm having a panic attack, to the most recent crisis call that we had was, I have a loaded shotgun and I intend to use it as soon as we get off this call. I have never, in my 15 years of being part of a mental health system, ever experienced the acuity level of crisis burnout with clinicians and crisis acuity levels with the patients that we see.
Well, thank you for giving us a case example, and I've heard you speak to this challenge of facing cases that are so much more serious. I guess the technical lingo is there's a greater level of acuity, but what a wake-up call to go from having lots of calls where people are facing anxiety, cats and trees and the like, to people with loaded shotguns saying that they're prepared to use them. So thank you very much for that and for coming. Dr. Durham, I want to talk to you about our challenges with parity. As you know, we got a Governmental Accountability Office report documenting all the barriers people face when trying to get behavioral health. The federal laws have been on the books. I mean, I remember the day my dad and I, talked about the parity law. We said, this could help Jeff Wyden, a schizophrenic. We rejoiced. And yet, what I hear is that there's still all kinds of barriers to patients getting the care they need. And I would like to have you describe what you think is really going on out there with the parity law. And I gather your patients are facing a lot of barriers, and you still don't think the spirit of the law that would treat mental health like physical health is being honored. I'd like to hear your words.
Thank you for the question, Senator Wyden. Completely agree that we have not made any headway with parity for mental health and physical health. We have a long way to go. A couple of really concrete examples is that I work in the psychiatric emergency room at Boston Medical Center. As I mentioned in my oral testimony, we have people that we've been at like triple, quadruple the capacity during the pandemic. One of the things that slows the process for us as a team of psychiatrists, licensed clinical social workers, psychologists, is that we evaluate the patient, we decide that they need inpatient psychiatric level of care, and then we start talking to the insurer. And that takes a lot of time, where we could be seeing other patients that are acutely in need of services by us. And we have to go back and forth, faxing paperwork. Then you have to do a bed search and seeing what psych unit will accept your patient. And if it's Medicaid or Medicare generally, they want to know for Medicare, well, have they met their capacity of days they can be on a psych unit? And then if they have total lifetime days, then we're stuck with the patient boarding with us until we can figure out what else we can do. And for Medicaid, it's a lot of back and forth for our folks. And so over 70%, or around 50%, I should say, of our patients, right, are on Medicaid. So that's a huge amount of time when we're in the emergency room spending going back and forth for essentially a prior authorization. And I like to use an example of when a patient comes into the emergency room and acute stroke or having a heart attack, the physician in that moment makes a decision that they need inpatient hospitalization, and they go to the medical floor without having to go back and forth with an insurer deciding if that's actually the appropriate level of care.
Thank you. And, obviously it was not the spirit of this bipartisan law, Senator Wellstone, Senator Domenici, to have patients and our providers have to go into what, is almost armed battle to try to navigate just a fair shake for patients and their providers. So I really appreciate your being here. I'm over my time. Senator Crapo.
Thank you, Mr. Chairman. This question is for you, Mr. Betlach. There's bipartisan interest in expanding opportunities for integration of physical and mental health services across all payers. While some approaches prioritize payment, others use co-location services or the use of case managers under a medical home model to achieve this goal. What are some of the examples of integration that could be a roadmap for Medicare or Medicaid in the near future, and how could waivers be used in state Medicaid programs to enhance access to care?
Mr. Chairman, Senator Crapo, thank you for the question. I think there's a lot of different approaches states can take, and certainly it depends upon the ecosystem of each unique state. I think the first thing it starts with is states need a strategy. What is your integration strategy? So as states think about this, they should be able to develop a plan in terms of multi-year strategies that they're going to be implementing around integration. And as I mentioned in my testimony, there's really 3 levels to integration. There's how you think about it at the policy level. And for us in Arizona, it was thinking about some simple things like what are the regulations that we have in place for providers to help build integration? Do we require some silly things like we had where you had 2 separate entryways and challenges around billing? And so making sure that as a state we were clearing out some of those regulatory burdens that existed for integration. States may or may not want to integrate and braid funding sources like we did in Arizona at the payer level, but states should certainly have a strategy around maximizing care coordination between payers. So if you're going to have a carve-out of behavioral health services, what are you doing to ensure that there's care coordination for individuals who require both physical health and behavioral health services? And then finally, states need a strategy in terms of how they're supporting providers in terms of integration. It may be opening up things like the collaborative care code model, codes in terms of being able to pay for services that are done at the primary care site, like Dr. Miller talked about. It may be other incentives. We leveraged in Arizona an 1115 waiver to create provider payments for milestones that were achieved in terms of advancing integration strategies like connecting to our health information exchange and other areas like that. So states need a plan, and the plan needs to address each of those 3 critical areas: policy, payer integration, and provider supportive integration.
Thank you. Ms. Jack, you've very well described the issues that you face in a rural community in providing the needed services we're discussing today. Unfortunately, the stigma around receiving mental health treatment can even be higher in rural areas. Can you speak to these challenges, and what approaches has your clinic taken to combat them?
I can. Thank you for the question. We have been integrated with primary care since 2012 through a series of SAMHSA and HRSA grants. We are partnered, as I said in my testimony, with a local federally qualified health center. And together, we have built a 20,000 square foot building to provide primary care, dental services, VA services, and behavioral health all under one roof. We are moving in, hopefully in August, and we are hoping that this destigmatizes your car from being seen in the parking lot, because people won't understand why you're there or what services that you're receiving. So this is one way that we thought in a frontier community we could reduce the stigma of people receiving services.
Well, thank you very much. And Dr. Durham, one of the positive outcomes of the pandemic has been, as we've discussed here, the significant expansion of telehealth, which is an important tool to expand access. Have you found any limitations to telemental health for treating your patients, and particularly the younger ones?
Thank you for the question. Absolutely, I think telehealth has been critical to meeting our patients' needs during this time, but there is a subset of the population that I think we need more research and understanding of how it's going to work fundamentally. I am a child psychiatrist that practices in a child clinic, and we went to telehealth pretty quickly as well, and I think it was difficult with some of our families too, because when we practice, we want a place where someone can speak to us directly. We want the parent to be separate from the room and that we can engage with the kid, whether that's a 5-year-old, a 12-year-old, or a 16-year-old. And it was very hard for some of the families that are in low-income communities, that are in multi-generational homes, to have that private place to have a session. And so that was some of the difficulty we saw. I think for little ones, especially kids that have early intervention services as well, so that 0 to 5 age range, we are also thinking about how we come back now to the office space again. And some of those kids we probably will need to see in person at some points during, and then maybe going back to telehealth once we've established a relationship. The little ones, it was a little bit more challenging. And I think for the adult population, some of our folks that have substance use disorders in particular and are homeless, really didn't have the technology necessary to always engage with that support. So throughout the pandemic as well, what we did was every day of the week, we always had somebody that was there in person in our clinics to make sure that people could get the care they needed and didn't have to rely on technology and not to get the services they wanted. So I think there's work to do. And I would also say that the audio only was critical during this time as well. And so any way we can expand that and make sure post-COVID, if you will, that we still get reimbursement for that, especially in some of our integrated care models, it was critical to have the audio only be reimbursed at the same rate.
Thank you. I'm out of time.
Thank you, Senator Crapo. Senator Stabenow.
Well, thank you very much, Mr. Chairman and Senator Crapo. And I really want to thank you for this hearing. It's been a while since we've had a hearing focused on mental health and substance abuse services, and I really appreciate your leadership. And to all of you, you've all raised issues that are so incredibly important. I want to speak specifically to what I think is foundational in the community. As Ms. Jett, you were talking about the certified community behavioral health clinics, because it goes to the core of integrating funding and really treating mental health and substance abuse as part of the healthcare system. I always say treating healthcare above the neck the same as healthcare below the neck, and not just through a focus on grants that stop and start. It needs to be integrated in Medicaid. It needs to be prospective payments so we can have the full opportunity for professionals being funded. So today, I'm really pleased to say that Senator Blunt and I, along with our chairman and Senators Daines and Cortez Masto and Smith and Tester, and welcome all the members of the committee to be co-sponsoring the next step. We have 10 states that have been doing a demonstration of how this can work with high quality standards. And today we introduced legislation that would allow states across the country to be able to do this, which is incredibly important. We have, through our startup grants, through the COVID process, we've been able to bring in dollars, as it's been indicated, to over 300 communities across the country, 40 states plus DC, to do startup grants. But what we need is comprehensive community care. And so, and this all really started, I have to say, because Senator Blunt and I worked together on federally qualified health centers, which are widely supported on a bipartisan basis. And the idea is you set up quality standards. If the community clinic can meet the high quality standards, then they get full reimbursement in the healthcare system. And so that's what this is. And the idea is to integrate those payments. And so, Ms. Jett, no surprise, I have questions for you to expand on CCBHCs. You really were one of the very first in the country and have done just a marvelous job and shown what can be done. But I wonder if you could expand more on the issue of permanent funding. You know, I've often said to colleagues, it's like someone having a heart attack and they go into the hospital and they're going to immediately get treated. Right now, in too many places around the country, as somebody walks into a mental health center, and it's the equivalent of saying, I'm sorry, the grant ran out, can you come back in a few months when somebody's in crisis, which obviously is ridiculous. So could you talk a little bit more about the importance of integrating funding and permanent funding in the mental health and substance abuse system?
Of course. I would like to give a couple of examples first about how the system is currently funded, which presents a variety of challenges for us. For example, on the Medicare side, only licensed clinical social workers or medical doctors can treat Medicare patients for mental health services. What this means in a frontier county is if we only have 1 or 2 licensed clinical social workers on staff, then the remainder of those services being delivered to Medicare patients are being written off. In our CCBHC, we write off upwards of $500,000 a year for Medicare-delivered services. Our growing population is over 65 and under 17. We have the under 17 covered, but the over 65 population is underserved. And really the reason is we don't have the licenses available to treat those people. So the funding for CCBHC allows that wraparound payment to bridge the gap of services not being currently financed. It's vital, and it's important that we fund the business of mental health. People just want to fund the services, but there's an actual infrastructure that's required to provide this high level of integrated care.
Thank you so much. And in the limited time I have left, let me ask you to speak a little bit more to integrating care. Again, the financing model really is about integrating primary care for individuals. It's a whole person, and we segregate them when we are talking about various ways to provide health care. But could you talk about the delivery of behavioral health services and what you do in the context of providing primary care for people?
Sure. Well, the CCBHC model in Oregon allows for 20 hours or more of primary care to be delivered, as we say, on our turf in the behavioral health system. This building, co-located with our local FQHC, works both sides of that equation, right? Because we understand that there are many people who want to access behavioral health services, specifically those with persistent and severe mental illness, on the behavioral health side. Conversely, there are people on the primary care side who only want to access behavioral health services from their primary care doc. And so having both an FQHC and a CCBHC in one location allows for multiple access of services and integration.
Thank you very much. Thank you, Mr. Chairman.
I thank my colleague, and Senator Crapo and I will be working very closely with you and Senator Daines as we go forward on these issues in a bipartisan way. Let's see. What we're going to do, because I think a couple of our hearings, it's been a challenge with so many senators having hectic schedules, I'm just going to call the names in order of appearance. So Senator Grassley would be next. I am not sure he's available, but I thought we ought to check. Senator Grassley. Okay. Senator Cantwell is, of course, here, been a longstanding leader in terms of health care advocacy. So let's recognize Senator Cantwell.
Thank you, Mr. Chairman, and thank you and the ranking member for holding this important hearing, and my colleague, Senator Stabenow, for her leadership on this. Many of you have mentioned, well, a big theme this morning is the integration of mental and physical health. And appreciate everybody honing in on what we could do about that. To me, this is, when I look at 20 to 25% of the homeless population is mental health problems, I think these are costs. These are just continued costs to the system that we haven't taken care of. And if we had an integrated system, and I think even better case management, because who's managing the situation? If the person has mental health problems, who's managing the situation? And if no one can talk to any of the people, how could you possibly integrate the physical and mental health? And I'm sure I'm not telling you anything. The drugs that people are taking for mental health cause a lot of physical problems. So this has to be fixed. So what do you think we can do to, get our colleagues to understand that we are losing money that we could save now if we would just fix this integration? So either Dr. Miller, since you were very big on this, or Ms. Durham, either one.
Well, Senator, thank you for the question. And I'll just begin by saying that I think you put your finger right in the center of the biggest problem that we have, which is how we have bifurcated, trifurcated, and split apart health. When you talk about services for the unhoused, or you begin to look at our children versus adults, we have fragmentation at almost every level. So to integrate requires us to have really thoughtful strategies that look at the issue at multiple levels simultaneously. And I'll give you one example of that. If we simply look at how we clinically integrate care without paying attention with how we financially support that integration, it usually falls apart. If we don't look at the administrative or operational functions that also provide oversight, it means that a lot of well-intended folks out there trying to bring those integration services together usually fall apart because there's not a structure for them to ultimately be grabbed by and supported. So when we look at health, it's our opportunity to really think about that integration at multiple levels. So thank you for the question.
Dr. Durham?
Sure, I'll add, thank you for that question. I think it's, I'm very aligned with what you said about case management and those services needed for families that come in with present with a lot of issues besides just the mental health issue. And our model for Team Up for Children, which is in FQHCs in the Boston and Greater Boston area, we have a community health worker as part of the model for just that, to do some of that care coordination, not only between the schools, but thinking about housing insecurity, food insecurity, and what other services are needed. I think what happens many a times, though, is that the case management service, the community health worker, or even a peer coach aren't usually reimbursed by the system, and so it does end up being a lot of grant funding. And I appreciated what Ms. Jett said as well, is that the grant funding ends, and then all those services that help support families and patients also go away. And so ways that we can embed that more into the system from a reimbursement perspective would be fantastic.
Well, I just go back to an example of the chairman knows I'm a big supporter of affordable housing too, but hospitals are now helping to finance affordable housing. So you can have a roof over somebody's head so that they don't keep coming to the emergency room. And while you're talking about helping families, I'm talking about the cost to the system when people have no support or no help. I don't think we have a clue about how much we're running up the bills, that we could do a better job if we just had integration and case management for these people. Then we could make better decisions and lower the cost. And so I hope we come to understand this, because a lot of our, I think what we're seeing in homelessness are people who've just literally fall through the cracks. They don't have anybody advocating for them. They've bounced in between these things. They don't have the issue taken care of, and next thing you know, they're out on the street. And this is then costing all of us in all sorts of other ways. So to me, let's understand that this is a task certainly about helping people, but it's also a task about fixing the system that is costing us way more than it needs to cost us at this point. Thank you, Mr. Chairman.
Thank you, Senator Cantwell. And as usual, you go right to the heart of the case, which is who manages a lot of these cases? Who is in effect in charge? And as I saw with my late brother, as he suffered from schizophrenia, he got good care in a number of instances, but too often we couldn't figure out who was in charge. And I said to myself, continually through this, odyssey, if this is what an elected official who's tried to specialize in healthcare faces, and I spent years and years in those communities playing basketball, what is it like for the typical person? So thank you for hitting the question of who's going to manage these cases, and Senator Cantwell says it so well, as always. Senator Thune, I believe, is out there on the web. Senator Thune, you available?
Yes, sir. Thank you, Mr. Chairman. And thanks to our panelists for being with us today. I think most everyone can agree that telehealth has proven to be an important tool in our tool belt for increasing access to mental health services. And once we get past this pandemic, I have concerns about a policy enacted last year that will require an in-person visit for Medicare to pay for tele-mental health. One of the things I hear everywhere in South Dakota, and it doesn't matter what the provider setting is, whether it's Indian Health Service or the VA or our public hospitals in South Dakota, our schools, we can't find, recruit, and retain providers. And so as we're talking about the need to increase access, it seems to me that this arbitrary and inconsistent barrier doesn't make sense. And in fact, in rural America, it stands to make access even more inequitable. Ms. Jett, can you share some perspectives on how telehealth has helped rural patients overcome the stigma of seeking mental health services and the potential challenge an in-person requirement can have moving forward?
Of course, thank you for the question. Of course, there are both pros and cons to receiving telehealth services. I'm happy to say that our clinic provided services nearly seamlessly through the pandemic because of the use of telehealth. However, as Dr. Durham had pointed out, those in underprivileged or underserved communities often struggle with technology, and as well as appropriate hotspots or Wi-Fi capability. And so what we've done as a community is we took some of the FEMA crisis money that we received and we bought 10 iPads and 10 hotspots to deliver to children and families and community members that were without Wi-Fi or technology services that were available to them. We would often have them drive into the clinic, park into the parking lot. We would walk out an iPad and they would hook up to our system right there in the parking lot and have their psychiatrist appointment or therapist appointment right there in the parking lot. So telehealth services has certainly expanded the access, but also has prevented some people from accessing services too, specifically the population with severe and persistent mental illness. This has been a great barrier to them. Unfortunately, it's very difficult to explain to someone with severe and persistent mental illness that their therapist is on the TV. That's a little odd. So it's been a bit of a challenge with that particular population. But overall, I think it's improved access.
Well, thank you. And I guess I would direct this to anybody on the panel. The in-person requirement passed last year is not consistent with multiple telehealth policies previously enacted by this committee, like the E-Treat Act for substance use disorder and the FAST Act for stroke. Would you support legislation to remove the face-to-face requirement for mental health like Senator Cassidy has introduced along with Senators Cardin Smith and I? And keep in mind that there's nothing to stop an individual provider from requiring their patient to have an in-person visit. And to Ms. Jett's earlier comment, I serve on another committee, the Commerce, Science, and Transportation Committee, which is working on the Wi-Fi issue and trying to make those services more available to more people across the country. But with respect to this issue, this piece of legislation that Senator Cassidy is leading and some of us are co-sponsoring, anybody want to talk about that particular legislation, whether or not you think that's something that you all could support and that makes sense as we look at better solutions to deal with mental health challenges facing this country?
Yeah, I can take that. I think that having a 6-month in-person provision will really be an unnecessary barrier to folks getting care, and I think it should be at the discretion of the clinician or physician seeing the patient whether or not they need to see them again for an in-person visit. And I think we would go down this road again of it's a parity issue of why certain illnesses or disorders you don't need it, and for mental health you would need it. So I would be very aligned with if we did not have this provision and just use the discretion of the clinician of whether or not they need an in-person evaluation.
Great. Anybody else?
Well, I think the bottom line is we just have to be a flexible system that's amenable to serving all people of all populations at any time they request access for services. So requiring these barriers seems sort of silly to me. And I hope that we can think twice about something like that.
Especially as the beneficiaries have now seen the value in receiving services through this mode.
Sure.
Okay, great. My time's expired. Thank you, Mr. Chairman.
Thank you, Senator Thune, and I think you're making very important points with respect to these various issues requiring a previous appointment in order to get to telehealth. We've got to work through those issues, and we're going to do it in a bipartisan way. Senator Grassley would be next.
Thank you, Mr. Chairman. In 2019, I passed the bipartisan ACE Kids Act with the help of Senator Bennett. It will align Medicaid rules and payments to incentivize coordination and improve health outcomes. This Congress, I'm working with Senator Bennett to build onto the ACE Kids Act with Accelerating Kids Access to Care Act. A key aspect of this effort is to enable the pediatric health home to coordinate care with children, including the prevention and treatment of mental illness and substance abuse. So for Mr. Betlach and Dr. Durham, you both discussed in your written testimony the importance of care coordination and addressing fragmentations in the healthcare system The ACE Kids Act requires states to ensure mental health care coordination is included when establishing a pediatric health home. What lessons can be learned from both your experience as a provider and a state Medicaid director with upcoming implementation of the ACE Kids Act in 2022?
Thank you for the question, Senator Grassley. I think the more we can coordinate care for kids and families, the better at any opportunity. Kids are in many different systems, school systems, their community, their family network, and all of their providers, especially as kids have more complex medical conditions. And so I would be in great support anytime we can provide the services to coordinate care, the better. And I think what we've seen in some of our models that have focused on pediatric and mental health integration in FQHCs is that the more members of the team that are involved with every system that the kid is in, is the better, it's better for the kid. Their mental health gets better, their physical health gets better, and then, of course, where they thrive is at school and at home, ultimately. So thank you for that question.
Yeah. Senator Grassley, what we've seen in Arizona is that states need to have a strategy around the different silos that exist in terms of where complex kids may be, whether it's working with the foster care system, whether it's working with kids that may be receiving services through a waiver for individuals with developmental disabilities. Really, the state needs to be looking at the delivery of behavioral health services holistically and how it's going to serve those populations and reduce the fragmentation. And so it's leveraging the investments that SAMHSA has made, for example, with first episode psychosis, to make sure that Medicaid is plugging into the infrastructure that's being created and looking at that. So if it's using managed care or fee-for-service, the state needs a plan in terms of how it's going to take kids with these complex needs and get them the services that they need.
Yeah. Last Congress, we made mental health services via telehealth a permanent benefit of Medicaid. So for Dr. Durham and Dr. Miller, as healthcare providers, how best can Congress support this expansion of mental health while ensuring improved health outcomes for individuals served on the expansion of access?
Access has been greatly improved with telehealth. We've seen that throughout the pandemic and with our patients. You know, as we discussed previously, I do think there are certain populations that it is more difficult. And so audio only has been very helpful throughout the pandemic. We've seen that a lot in some of our integrated care settings, whether that's pediatric integrated care or the internal medicine integrated care for primary care, at least in our, at Boston Medical Center. And so I hope that the provision would still continue to allow audio-only visits at the same reimbursement rates because it has significantly impacted and helped many of the homeless population, folks that don't always have access to the technology.
I agree with Dr. Durham and Senator Grassley. Thank you for the question. The uptick in telehealth utilization for mental health has been a very helpful sign that people like it when care is able to come to them. And if we're really going to put the patients and families first, we do have to consider policies like the in-person requirement we just discussed and consider whether or not these things are good or bad for people, because does it restrict their access? Does it restrict where they're going to be able to ultimately use these services? So making permanent the audio only, having payment parity, and allowing this for all forms of outpatient care is a tremendous benefit for so many people across our country.
I will yield, Mr. President, or Mr. Chairman.
Thank you, Senator Grassley. Next would be Senator Carper. Is he available on the web?
Senator Carper's right here.
Okay, and we can hear you. Go ahead.
Thank you, sir. Welcome to each of our witnesses today. My staff and I have heard from pediatricians from across the country, including right in Delaware, the Moores Children's Hospital, fabled Children's Hospital that we're very proud of. And we hear from any number of sources that our country is experiencing a mental health crisis among children and youth. And I don't think it's just in Delaware. I think it's throughout our country. But during the pandemic, children have experienced major disruptions as a result of public health safety measures, including school closures, social isolation, financial hardships, and gaps in healthcare access. It's become clear that COVID-19 has significantly exacerbated the health stress on children and youth, highlighting our nation's acute shortage of mental health services and the need to reinforce and expand the pediatric mental health delivery systems and infrastructure. A question for Dr. Durham, if I could. Dr. Durham, what more can those of us in the Congress do to address root causes and support effective approaches to prevention and early identification of mental and behavioral health issues? Dr. Durham.
Thank you very much for that question. As you mentioned, many of our kids experience a lot of loss, and when we think of loss, it's not only death within their family, but also thinking of not being able to see their friends or do the social activities and other things that fulfill their livelihood. I do think one thing that we need to think from a prevention promotion standpoint is that many of our schools, even in the Boston area, don't have school therapists that they have access to. So when we think, we don't want people to always get treatment with their severe level of illness, that they need to be in a hospital or an emergency room. And how can we start thinking in a prevention and promotion framework of just touches, if you will? So meaning something's going on, a teacher notes it, a principal or someone in the school or the family, and that they have the services right there within the school system before we get to the point where you're calling the emergency services or a crisis line. There's not enough supports within the school system to do any of that sort of prevention and promotion framework. Teachers are doing a lot. They're doing their job, but we don't have therapists that are even embedded in many of our schools, even when we think about a resource-rich place like Massachusetts. And so I think it is critical that we think about it in that framework. I do think pediatric integrated care is another way to think more about prevention and promotion. So seeing children and families at their well child visits, which we do in Massachusetts, and start thinking and asking those questions about what stressors are happening in their lives, and getting care for immediate needs, whether it's a mild, behavioral health need, depression or anxiety that isn't to the point where maybe they're thinking about harming themselves or harming anyone else. So using that framework of prevention and promotion, I think, is critical. And sometimes that is not necessarily reimbursed from a mental health standpoint as it is for physical health, that kids are supposed to go get their visits quite early in life for a check-in. And the more we can think about even like a mental health check-in with their primary care provider or therapist in the school, I think the better we would all be in the long run.
Yeah, thanks. A question for the record, if I could, for all of our witnesses. Several months ago, I was in the Bay Area in California and visiting a number of promising technology companies. One was called Ginger, Ginger, in the Bay Area. And they focused on coverage for, they focus on mental health screenings and behavioral health coaching. And I have a question regarding the coverage for those screenings and coaching. And I would just ask if any of our witnesses, if any of you find virtual behavioral health coaching to be an efficient means of preventing serious mental illness, and if so, should Congress consider mandating coverage for virtual mental health screenings and behavioral health coaching and plans offered on the health insurance marketplace? That's a question for the record for each of you. Thank you very much. Thank you, Mr. Chairman, for our ranking member.
Thank you, Senator Carper. So, colleagues, we're going to keep this going. Our guests will, I'm sure, find this somewhat entertaining because we've got all these votes and senators are coming in and going, but we're going to keep it going. The next four questioners from the committee will be Senator Cardin, Senator Cassidy, Senator Bennett, and Senator Daines. So Senator Cardin, if he is available on the web, would be next. And as I say, we're just going to keep this going. Senator Cardin, you out there in cyberspace? Okay. Senator Cassidy has been here all morning.
Thank you, Mr. Chairman. Dr. Durham, I think I may have given you a lecture in medical school.
I think you may have.
I don't know, you may recall it was on diarrhea and hepatitis. I was very famous on those lectures. So there will be a quiz as to hepatitis A and how it's transmitted, but we'll do that off the record. Thank you very much. And it's incredibly gratifying to me to see you and how your career has gone. So let me say that.
Thank you very much.
Let me echo Senator Thune's endorsement of the bill that we have introduced as regards telemental health. And Mr. Chair, I'd like to submit two letters which support this legislation that we're putting forward with Senators Thune, as he mentioned, but also Senator Smith and Cardin, and I've lost the list, but it's a very, and Smith. And so this letter is from the American Telemedicine Association, and this is a group of folks all with the Health Innovation Alliance of the American Telemedicine.
Without objection, so ordered, Senator Cassidy, and Senator Crapo and I will be working very closely with you and the coalition on it. I think it's a very important idea.
Thank you. Mr. Betlock, good to see you, man.
Senator Cassie, good to see you, sir.
Your hair's a little longer. I mean,
It
you know,
is,
it's,
yeah, part of the-
Listen, several questions for you. You and I both know, in fact, we all know, dual eligibles are just a terrible mess. Very expensive to care for with terrible outcomes. We're spending incredible amounts of money to get terrible outcomes. It is the worst of all. Now, SAMHSA puts a lot of grants out there in order to address the mentally ill, the issues of the mentally ill, as well as those who have substance abuse. And yet there seems to be poor coordination with Medicaid. You've got experience. Can you give some ideas as to how we could better coordinate those programs?
Sure, Senator Cassie, that's an incredibly important question. In Arizona, roughly 40% of the population of individuals with serious mental illness are dual eligible members. It actually leads to incredible fragmentation, as you described. When I first became the Medicaid director, if you're an individual with serious mental illness, you had a plan for physical health for Medicaid, a plan for behavioral health for Medicaid, Medicare fee-for-service, Medicare Part D. You had 4 different organizations that were potentially involved in paying for your services, none of them coordinated. As you said, it's led to just terrible results. On average, an individual with serious mental illness dies 25 years younger than peers, and oftentimes it's from untreated chronic diseases. And so in Arizona, it all comes back to the system design issue. Who's accountable in this? And it's very challenging with dual eligible members. But we created and built off some of the federal regulations that exist that said the managed care organization that was responsible for providing services for individuals with serious mental illness not only had to deliver Medicaid services. Arizona Medicaid program's the 3rd largest housing authority, so there were rental subsidies that were flowing through the Medicaid program, employment support services. Very importantly, the plan had to be a dual special needs plan, which meant that it offered the Medicare services, which meant it was then accountable for delivering Medicare services to that population.
So let me stop you.
Yes?
Great ideas, aligning incentives, appointing authority, everything that checks the box in terms, what were your outcomes? Were you able to improve outcomes for the duals?
Yes. In the independent third-party study that was done by Mercer, we saw an increase in terms of all the HEDIS scores for ambulatory and chronic management, and an increase in all of the CAP scores.
Now, let
which is
me
the
ask,
member
because
experience.
sometimes those are process-oriented as
Yes.
opposed to outcomes-oriented.
Right.
And so to what degree did you see emergency room visits decrease, return to workforce, longer lifespan, et cetera?
We don't have the indicator yet on longer lifespan. We're only a few years into this, right? So that's going to be a lagging measure as we look at the different indicators. But we did see a decrease in emergency department utilization and increased use of primary care. Again, so not necessarily outcome measures, right? But it's a start in
Let me
all of
ask
this.
them, because I'm almost out of time.
Yep.
And specifically integrating SAMHSA grants in there, were you able to do that as well?
We did. We flowed all of the SAMHSA block grant dollars to that organization. They were responsible for those as well. So again, a single accountable organization that had all those dollars braided in it.
Gotcha. Thank you all for your good work. I really appreciate it. And again, Dr. Durham, great to see your success.
Thank you.
Thank you. I yield back.
Thank you, Senator Cassidy, and we're going to be working very closely with you as we go forward on this committee effort. Senator Bennett is next.
Thank you, Mr. Chairman, and again, thank you very much for holding this hearing. I hope that it's only the start of a larger effort to address the mental health issues in our country. I, like my colleagues, am deeply concerned about the issue of parity and how insurance companies and providers often erect barriers to adequate mental health coverage. And as Senator Kane and I were working on developing our Medicare X Choice Act to create a public option, mental health access was at the top of our mind. We viewed this as an opportunity to improve access to people, especially in rural areas. And a key provision in this proposal provides primary care to patients with a public option without cost sharing, and this should absolutely include mental health care. Dr. Miller and anybody else on the panel who'd like to answer, can you speak to how a public option could be designed to integrate mental health and primary care? How should this elevate the standards on parity that currently don't exist in the private health insurance market?
Thank you for the question, Senator Bennett, and thanks for your ongoing leadership in this space. First, from a coverage perspective, any public option should incorporate some of the key lessons that we're learning from landmark federal cases like Witt versus United Behavioral Health. This includes things like requiring coverage to be consistent with generally accepted standards of care that ensures the inclusion of civil enforcement provisions. Second, a public option can actually create a standard for integrating care. A public option can determine the scope of services, and it can actually raise the bar on expectations for integrated practices. This is needed and overnight could create a new mechanism to support integrated primary care. And then finally, a public option could expand the scope of services and range of providers to make sure that it pays for critical services that augment the on-site delivery, like peer support specialists. These things really, if you bake it into a public option, you are beginning to change the game from how people experience mental health and primary care on the ground.
Anybody else? I am deeply concerned with the increased rates of mental illness that young people are experiencing, leading to death by suicide, substance use, or other mental and behavioral health challenges. In Colorado, it's been 5 years since suicide became the leading cause of death for kids age 10 and older. And at the same time, we've seen a reduction in beds for youth suffering from mental illness. We've seen that decrease by 1,000 in the past decade. A few weeks ago, our Children's Hospital declared a, quote, a pediatric mental health state of emergency, as emergency mental health visits were up 90% in April 2021 compared to April 2019. What gaps exist in the tools needed to address the mental health challenges facing our children and young adults across the continuum of mental health care, particularly for the Medicaid population? I know a lot of our colleagues are working on improving home and community-based services. How can we ensure kids and families are receiving mental health services at home or in their communities? I don't know, Dr. Durham, whether you might want to get us started.
Sure, I can get us started. I think it's a fantastic and great question, so I appreciate it. I think it has to do a lot, too, with the care continuum. I think what we've seen is everything has been exacerbated. What we knew pre-pandemic was that we don't have enough services for kids. I think a state like Massachusetts has done a good job. Senator Cassidy is from Louisiana, which is my home state, which is very different, and my family and friends are still there, and I can compare Massachusetts and Louisiana. And so we do have a continuum for care. We have in-home services for kids on the state Medicaid in Massachusetts with different language capacities. And I think that model should be replicated in other states similar to the state of Louisiana, where I come from, where there is very limited resources for kids on the state Medicaid. And that care continuum has day programs in Massachusetts. We have crisis units for kids so we don't have to go always to the highest level of care, which is a locked psychiatric unit for kids. And, as previously stated, I do think we need to do something to expand school-based therapists at schools. We don't have enough. That is where kids are most of the day. That's what gets noticed quickly by teachers and other people that see them day in and day out. And so ways that we can work from a prevention and promotion framework, kids as young as 12, 13, and 14 will tell you when they're in their early 20s, I knew when I was 12 that something was going on. And either maybe a parent or caregiver didn't recognize, but also there was no one to go to. So the more that we can invest in that all the way from prevention and promotion along the care continuum, I think the better for all of our kids.
Thank you, Mr. Chairman. I'm out of time, but I appreciate that answer very much.
Thank you, Senator Bennett. The chairman has gone over to vote. I don't know if it's been explained that we have 2 votes going right now, so we're kind of rotating back and forth. Plus, we have a lot of members who may or may not be available because of that, but I'm just going to go down the list. I am told that Senator Daines is on his way here, but let me just ask, is Senator Daines on the internet? All right, I'm just going to call out some names, and if nobody answers, I'm going to... Did I just hear somebody? If nobody answers, I will ask a few of my own additional questions. Senator Casey. Senator Young. Senator Warner. Senator Whitehouse. Senator Hassan. Here is Senator Daines. You're up, Steve.
Mr. Chairman, thank you. And truly, I'm very glad that we're holding this hearing today. It's such an important topic. Last month, Senator Stabenow and I hosted our first Finance Healthcare Subcommittee hearing of the year. Since May was Mental Health Month, we focused on the importance of improving access to mental health services and how the COVID crisis has impacted patients as well as providers. We're fortunate to have Lynette Kozovich as our Montana witness. She's a CEO of the largest behavioral health organization in Montana. And she was able to highlight the challenges our rural communities face when it comes to accessing mental health care. She also discussed the benefits of the Certified Community Behavioral Health Clinic model, known as a CCBHC model, which brings a reimbursement for behavioral health services on par with that for physical healthcare services. In fact, following that hearing, Senator Stabenow and I decided to team up. We introduced legislation to allow states, including Montana, to adopt the CCBHC model. In fact, we're introducing it today. Our bipartisan bill will integrate the physical and the mental health care and provide patients with access to treatment more quickly. Ms. Jett, how can the CCBHC model help rural communities like those in Montana that face access challenges and have a shortage of mental health professionals?
Thank you for your question. We really believe in the CCBHC model. In fact, we've been one of the first adopters and have been using the model for about 4 years now. We find that integrating the services or creating what we like to call the neck in between the head and the body really helps improve outcomes for patients that we serve. It also improves access to underserved populations, specifically veterans in our community have really benefited from us becoming a CCBHC, primarily because Oregon wrote a waiver with the CCBHC model that would allow veterans to access care from non-veteran clinics. So where we live in Northeast Oregon is about a 2-hour drive for any veteran receiving any sort of services, medical or mental health services. And so by becoming a CCBHC and along with that Oregon waiver, we are able to treat local veterans for behavioral health issues. It's been really powerful.
As a son of a veteran, thank you. I recently introduced legislation with Senator Cortez Masto to make permanent a CARES Act policy that I championed, allowing first dollar coverage of virtual care under these high deductible health plans. Our bipartisan bill would allow Montanans and Americans across our country to continue accessing essential care like mental health and primary care services without the burden of first meeting a deductible. With more than 50% of American workers now receiving their health care coverage through these high deductible health care plans, I believe this policy should be made permanent. Question for Dr. Miller. Do you agree that limiting barriers to telehealth services after the public health emergency would benefit patients seeking mental health services?
Senator Daines, thank you for the question. As we've discussed today, there's such power in being flexible with how we're able to deliver services to where people are. And so what we need to do is continue to explore how these services have added value to people's lives and how they've improved outcomes. Many of the changes that we've seen through the emergency order have made a difference in countless lives. And I think to take that away would not only be to the detriment of those families that have become dependent on it, it would also hurt our overall nation's health. And so we have to be very thoughtful and very considerate when it comes to these issues of telehealth. I would recommend that this group, this committee, and this Congress really consider ways to either make some of these changes permanent or to consider an extension that goes on for the next year to 2 years to allow for us to continue to maximize on what many folks have benefited from.
Thank you. I want to shift gears and talk about a problem we're facing in Montana, and that's meth. In Montana, meth is taking a devastating toll on our families and our communities. I had a briefing with our guard in Montana on Friday, their counter-drug task force, and they're talking about significant increases year over year in 2020 versus 19 here on drug seizures in our state, meth and heroin. In fact, in 2020, drug overdose deaths hit a record high, and we're now witnessing a disturbing increase in meth-related violent crime. While medications can be effective in treating some substance use disorders, there are currently no FDA-approved medications to help meth addiction. According to the National Institute of Drug Abuse, contingency management, which involves giving patients incentives to not use drugs, is an effective treatment for some individuals suffering with addiction. Mr. Betlach, in your experience, are there any federal barriers that prevent states from implementing effective contingency management?
Senator, thank you for the question. I would say I'm not aware of any, but we can do some further research and get back to you.
Okay, thank you. Thank you, Mr. Chairman.
Thank you very much. And I do understand that Senator Young is on the web. Senator Young, are you there?
I am, Mr. Chairman. Thank you so much for holding this hearing, and I think this is a really important topic. The coronavirus outbreak has created an unprecedented mental health challenge for our country, and I know it certainly created challenges back home for many of my Hoosier constituents. While we don't yet know the full impact of the coronavirus pandemic on mental health, we do know it's forced Americans to isolate from their loved ones and other support systems, causing a troubling spike in mental health and substance abuse problems. A Kaiser Family Foundation poll found that 45% of adults say that the outbreak has affected their mental health, almost half of adults. Among adults in Indiana who reported experiencing symptoms of anxiety or depressive disorder, almost 20%, 1 out of 5, reported needing counseling or therapy, but not receiving it in the past 4 weeks. I have a few questions related to this directed towards Dr. Durham. Dr. Durham, access has long been a barrier to adequate behavioral health care. The public health emergency is only exacerbating existing challenges and increasing need for providers and treatment. How are providers responding to this increased need?
Thank you for the question. I think that you're absolutely correct that we've seen a lot of people and a lot of uptake in services because of what we've all, I think, noted today is that there's been an increase in flexibility when we've added audio and video telehealth capability to all of our clinics, throughout the country. And like most have said previously, I don't think we should change that moving forward. We need to meet people where they are and whenever they can access the technology without having to necessarily come and drive into appointments, or if you're in a rural community where you may not have access in your community to a mental health provider. So what has happened is that our clinics are full. We are seeing people back to back with telemedicine and our audio appointments. And what it leads to is that, we have a workforce issue and we need to figure out ways that we can expand on who is able to provide care. As Ms. Jett mentioned earlier, there are certain insurers that don't allow for certain services to be provided. And so looking at that more deeply of who can provide services and get reimbursed for their services, I am a firm believer that whatever you trained for and went to school for, you should be able to practice and get reimbursed appropriately for. And so I think that telehealth has expanded so much for our communities. I think there's more research to be done as well for which which patient populations it works for and how we need to pivot in some other ways to make sure it's accessible for them too, due to other digital inequities and maybe the lack of digital literacy as well. But it has definitely made that process of engaging and reducing stigma, I think, in mental health, with having to physically come in to see a mental health provider, I think it's helped substantially.
Well, I agree that these additional flexibilities based on my consultation with providers back home have just been essential. So I think it's really important that we continue to maintain these flexibilities. If time remains, I'll briefly touch on social determinants of health, because we know that these are the economic and social conditions in which people live and learn and work and play, and they also impact one's ability to access transportation and stable housing, and by extension, these factors can positively impact the health and well-being of the most vulnerable Americans. So, Dr. Durham, once again, just briefly, how might we better leverage existing programs and address the barriers to coordination between mental health and some of these social service programs that I alluded to? Is there anything that comes to mind that you see as a real opportunity for us in Congress?
So I can talk based on my experience just as a clinician and someone who works in outpatient child psychiatry. We have folks at Boston Medical Center that exactly what you mentioned. They're struggling with food insecurity, housing insecurity, transportation issues, all of the social determinants. But what is lacking, because most times from a Medicaid perspective, we are not necessarily reimbursed for that time that we take to coordinate the care. It is very difficult to get case management as a psychiatrist or as a social worker in our clinic, or we have LMHCs in our clinic. The time dedicated to coordinate all of those services that family may need from a case management standpoint are not necessarily reimbursed. And so that happens or carved out at other times during the day when maybe we have a gap, if you will, in our schedules. And I wholeheartedly agree that a person's mental health is affected by all of those social determinants. And the more that we can think about how do we provide care and get reimbursed so that we can talk about all the social determinants, get them the services they need, and also as a provider focus on their mental health, I think the better, you're right, our families would be and then the communities would be ultimately. But many a times that mechanism is funded by grants, and grants go away. And then we're stuck with how do we help our families with all of the needs that they need in order to focus on the mental health issue at hand.
Thank you so much. Yeah, sustainable reimbursement for transportation to a primary care provider in an underserved population, so that we don't end up paying as taxpayers for something that becomes far more costly in the longer term, and certainly costly to that person's health. Reimbursement to replace an air conditioning unit so that somebody doesn't, or a heater, so that somebody doesn't become incredibly ill. It's the whole ounce of prevention notion, and we've just got to get better at that. So
thank you,
so
Senator
much
Young.
for your
We're going to
presence
need to
here.
move on to the next senator, which is Senator Casey, who I understand is on the web. Senator Casey?
Thank you, Senator Crapo, thanks very much. I just have one question, and I know this is maybe plowing ground that has been plowed during the hearing, but I want to reiterate some of it. And I'll direct my question to Dr. Durham and Dr. Miller. We know that even before the COVID-19 pandemic, that children were facing both behavioral and mental health crises all across the country. This need obviously is much greater because of the pandemic. And now kids are waiting weeks to months to get mental health, both the evaluation and the treatment. So it's highly unlikely to get markedly better even as the pandemic is receding. We've heard a lot today about telemedicine and the benefit it provides, but used alone, it doesn't help us with the question of increasing the number of trained professionals who can help both children and teens access the both mental and behavioral health care that they need. Primary care docs and nurses are often the first point of contact for kids and for teens and their families, whether they're struggling with anxiety or depression or substance use disorder issue. Yet too often, many of these primary care providers are believe they're not prepared to respond appropriately. So there's not a lot in the way of incentives to provide to child health providers to either engage in or expand their provision of mental or behavioral health care. So we know that lack of incentives can contribute to both racial and ethnic healthcare disparities, both in terms of care and outcomes. So to both doctors, Dr. Miller and Dr. Durham, how do we better support or incentivize healthcare providers, advanced practitioners, and other therapists to increase increase or enhance their ability to respond to these mental health needs?
Thank you for the question, Senator Casey. And I'll just begin by briefly saying that I think you have your finger right at the center of this issue, which is that people, families, children, they have to work too hard to get access to care. So how do we incentivize the places where the kids show up to make sure that they are providing adequate on-site mental health? And I think it begins with the flexibility of funding. One of the most profound barriers as to why people do not adopt integrated mental health care is because of the upfront startup costs. If they had flexible funding, what they could do is be a little more creative with how they were able to onboard a clinician to make sure that they were there in that pediatric setting to help that family and that child. Second thing is that we have to provide some level of technical assistance. Integrating care, as powerful and potent as it is, can be difficult. And so an added incentive beyond just the flexible funding is helping practices make that change, make that transformation. Without that, sometimes we see people start and stop because of the difficulty of it.
Thanks, Dr. Durham.
Yeah, thank you for the question. And, echoing, I won't echo everything Dr. Miller said, and I'll just add to it in that our team up model, which is at FQHCs in Boston, the greater Boston area, did exactly that, in which you have to have some funding in order for those health centers to start doing some of that work. And so that's what some of the grant initiative did. But then on top of that, I would say that what we've also added to that care team and make sure that it's a true team is that the pediatrician or the pediatric primary care provider does not feel alone, is that there is a behavioral health clinician and community health worker as a part of that model to get kids that have some of the most need. These are kids on our state Medicaid, to make sure, as the previous senator mentioned, that we are, tucking away housing and food insecurity and all of those other things so that we're not continuing to cost the system, but helping with that as well. But I do think that team effort, so that the pediatric primary care doc doesn't go at it alone. We have also integrated training within that, so they learn more about mental health conditions at the primary care level, which has been instrumental. And then also clinical workflows, because it is different when we've decided to start shifting from just physical health, but both to mental and physical health, that they have to shift their practice in some way. So the technical assistance aspect, I think, is also very key.
Thanks very much. Thanks, Senator Crapo.
Thank you, and I understand Senator Warner is now with us. Senator Warner?
Thank you, Senator Crapo, and thank the panel and the chairman for holding this hearing. I know we've been talking about a variety of mental health issues. I want to talk about one that's it's quite close to home with me in terms of my own family, and that is some of the challenges around eating disorders. We've seen from the Journal on Eating Disorders that about 62% of the individuals with eating disorders have seen an increase in stress due to COVID-19. We've seen a dramatic increase in binge eating as well. I've seen around Virginia, again, both on a personal basis and on a more global basis, how this disease can really challenge not only the afflicted, but whole families. Matter of fact, eating disorders has the highest incidence of mortality of any mental health issue. Dr. Durham, given your experience as a physician specializing in pediatric and adult psychiatry. What do you think, both COVID-related and non-COVID related, we can do to get ahead of this issue around eating disorders, from anorexia to bulimia to a host of other kind of manifestations of this challenge?
Thank you for the question. This isn't necessarily my area of expertise, but what I will say is that I understand and can understand how eating disorders, among many other disorders that we treat during the pandemic, they're on the rise. I think what happens when you're in a position of high stress, social isolation, lots of loss, that you end up doing, you don't have all those reserves, those emotional reserves that you had prior to the pandemic, and lack of all the social connectedness that we all wanted and thrived for. And so I think that's why we've seen rates rising in depression, anxiety, and folks maybe going back to some restrictive or binge eating behavior. And we've also seen that for folks with substance use disorders who had a period of sobriety for maybe years, and now during this time, unfortunately, relapse during this time because it has been stressful for everyone. And you sort of fall back to maybe things that felt more comfortable or that were habit forming at some point. And so now we've talked a lot too today about thinking about this critical time, but I don't think we've seen, we need that year or two to see the devastating consequences of this pandemic, because I think it's going to take time for people to get back to their normal level of functioning, if you will, and to their own baseline. And so whatever we can do to extend services for telehealth and other services and increase that flexibility, I think will be key moving forward.
I agree with you. I do think it's going to take us that time. What is the new baseline going to be? I mean, Dr. Miller, in your testimony, you noted the need to integrate mental health within the primary care field to modernize the workforce. The National Center for around Excellence for Eating Disorders trains primary care practitioners on screening, brief intervention, and referral to treatment, called SBIRT. Do you view these cyber trainings for primary care practitioners as helpful in addressing some of these workforce issues around mental health, not just eating disorder, but more broadly?
Yeah, thank you for the question, Senator Warner. And I think anytime we don't ask, we don't know. So we have to be able to screen to detect if there are issues that are under the surface that our patients, the families, our youth are not necessarily raising on their own. So I think it's a positive thing to screen. However, I have to point out that screening alone without treatment is insufficient. We need to be providing incentives, as we've discussed today, to onboard experts, clinicians who can help when those individuals do come forward with a positive screening, if it's an eating disorder, if it's anxiety, if it's depression. This is a very positive thing for us. It not only normalizes how people begin to talk about issues like eating disorders, but it also creates a team-based environment so that we can provide the most comprehensive care necessary for that patient.
Well, this is an area I wish, Mr. Chairman, I was not as much of an expert as I've become over the last 12 or 14 years, but I appreciate the comments. I wanted to go to Dr. Durham again. When we're talking about practitioners, we had an enormous tragedy with Dr. Lorna Breen in Charlottesville, Virginia, who was a emergency room practitioner that in many ways the stress and overwhelming nature of COVID-19 unfortunately led her to end up with the level of depression she took her own life. Along with Senator Kaine and others in Congress, we introduced the Lorna Breen Healthcare Provider Protection Act that would address professionals in terms of trying to make sure that we train folks on how to deal with these high stress circumstances. Dr. Durham, I know we're down to the last couple seconds. Do you want to comment on how we make sure that we take care of patients, but also our providers?
Yeah, in the last couple of seconds, I appreciate that and appreciate that that is happening, because we do need to take care of all of our providers. It's been an equally stressful time for all of us. No matter if you're a physician or a social worker or an LMHC, nurses, we have been working really hard. And I think that at a place like BMC, a lot of things that have happened where they were even just doing like wellness check-ins for all of our staff, from people that deliver food to patients' room, to physicians, to the nurses. And I think that that's important. And anytime we can integrate more initiatives for the workforce, I think the better. We're going through this equally as all of our patients are.
Thank you, Mr. Chairman. Thank you, Dr. Durham.
Thank you, Senator Warner. Our next three are Senator Whitehouse, Senator Hassan, and Senator Warren. Senator Whitehouse, you out there?
Thanks, Chairman. I am out here, and I appreciate this hearing very much. Quick thing first. One of the things that I've gotten for feedback from my mental health community in Rhode Island is that the increase in telehealth during the COVID had kind of a hidden benefit, very hard to quantify, but I heard it repeatedly, and that was the sense from practitioners that the qualitative input that they were getting through telehealth was actually better, more meaningful than beforehand when people had to, find their way across town, wait in the waiting room, fill out the stupid clipboard, go into an unfamiliar room, and then have a chat with the practitioner. That to be able to do it from a place of safety at home seemed to bring out better interaction, better substantive, qualitative interaction. And I'm wondering if any of you have had that experience, or if you've seen anybody. I know it's hard to quantify. Has anybody tried to quantify it in any way?
Thank you for the question, Senator. The only thing I would add to that is that in talking with providers, not only have they heard that from an impact, but also a lower no-show rate. So in addition to being able to have a better impact, you also have people showing up more for appointments. They haven't had conflicts. They haven't had transportation issues. So a number of those factors have been taken out of the equation, and as a result, more people have accessed services.
So let me leave it at that. And if anybody else wants to expand on that for the record, please let me know. But I'm going to take it as the agreement of the panel that there were those two improvements, both in showing up and in being engaged and being, getting better engagement as a result of telehealth. The other topic I wanted to go on to was the interface between law enforcement and mental health, which plays out first directly on the street with law enforcement, and then depending on how the individual engaged with law enforcement, maybe at the local police station or jail. And if not, then usually a ride over to the emergency room where they get dropped on the unhappy ER docs to cope with. So Senator Cornyn and I are working on a bill to improve the engagement of law enforcement in this space so that there's accredited, curriculum and training programs for people so that they know they're getting like the real deal in terms of training, to improve crisis intervention teams and their engagement with law enforcement, to figure out how to improve the referrals to community-based mental and behavioral health service folks, to improve de-escalation tactics. All of this, I think, is pretty important. And I just wanted to get your sense, anybody who'd care to respond, on the extent to which law enforcement today is the entry point for people who are in need of and have not received adequate mental health and behavioral health services, and the extent to which it's a successful entry point.
Senator, thank you for the comments. In terms of the interaction between the mental health delivery system and law enforcement, I guess I would invite you to come out to Arizona and see what's going on with regards to the crisis system in our state, in which not only do we have robust mobile response teams, but also crisis stabilization facilities to be able to work with law enforcement. There are thousands of drop-offs that occur annually within a 5-minute time span oftentimes. There's also a lot of training in terms of the CIT model that you mentioned. So clearly there's a role, from my perspective, that Medicaid should be playing in helping to support the interaction and support of law enforcement, mental health providers through a stabilization, crisis infrastructure. That really, there's been a lot of discussions and a lot of new resources for states to be able to establish more robust systems. There's also going to be an expectation from individuals as they dial 988 in the future in terms of what types of infrastructure will be available for individuals.
Thanks, and I think my time is running out, so if anybody else has best practices or really good local examples that you'd like to share with us, if you could please get that information into the committee, both Senator Cornyn and I would be very grateful. Thanks all for your terrific work and for helping get us through the COVID situation.
Thanks, Senator Whitehouse, Senator Hassan, then Senator Warren.
Well, thank you, Chair Wyden and Ranking Member Crapo for this hearing, and to all of our witnesses, thank you so much for taking time to be with us today. Dr. Miller, I want to start with a couple of questions to you, and then I'll move on to the other panelists. The demand for mental health and substance use disorder treatment and services skyrocketed during the COVID-19 pandemic as millions of Americans grappled with grief, isolation, and economic uncertainty. We've helped meet that demand by providing new means to access mental health and behavioral services such as telehealth, and there's been a lot of discussion about that this morning. Unfortunately, even as we move to make it easier to access some services, the stigma still associated with substance misuse prevents too many people from getting the behavioral health services they need. Dr. Miller, how does the stigmatization of substance use disorder impact access to treatment and services, and what steps can Congress take to better integrate substance use disorder treatment into primary care settings?
Well, thank you for your question, Senator, and thank you for your ongoing passion and leadership in this space. To your point on stigma, we know that only about 10% of individuals with substance use disorders receive care. And that tells me a lot about stigma. It says both that socially that we don't talk about it as much as we should, but more importantly, however, structurally, we have these fragmented ways of individuals being able to get access to care. One of the themes that I think you're very familiar with and that we've discussed today is that we need to make it easier for individuals who are identified with a substance use disorder to be able to access care. That means bringing that care to where people are. We have to train up our providers to identify it. We've got to train up our clinicians to treat it. And we've got to recognize that undergirding all of the substance use disorders is also mental health. The reasons that we provide gold standard treatments for things like substance use disorders is because we need to provide counseling at the same time. This is how we begin to destigmatize substance use disorders and hopefully encourage more people to seek care.
Thank you. I'm also continuing to work on trying to change the X waiver requirement as we move forward, because I think that stigmatizes the provision of treatment for some healthcare providers too. Dr. Miller, I want to turn to another devastating public health crisis that we have to work on, which is the issue of youth suicide. A report published yesterday, and Senator Wyden mentioned it earlier, by the CDC found that earlier this year, emergency department visits for suicide attempts by adolescent girls increased 51% on average when compared to 2019. And I've heard directly from New Hampshire students about the mental health concerns that they have. That's why I've introduced the Bipartisan Stand Up Act with my colleague, Senator Ernst. That's going to encourage the implementation of evidence-based policies and trainings in schools and communities across the country that will help to prevent suicide. Dr. Miller, can you speak to the importance of providing kids and teenagers with the tools that they need to recognize if they or someone they know is at increased risk of suicide?
Thank you again for the question, Senator. As a father of two children, I can tell you this is the one that I really want to make sure that we get right. We teach our youth, our kids, all about aspects of physical health. We even teach them things like how to drive a car and even how to save someone's life with CPR. And so, yes, we have to be able to equip our youth and our schools, frankly, where our youth are basically there a lot, with the ways to identify issues related to suicide. In fact, there was one survey that came out from Mental Health America that showed how youth are more talking to each other around issues of mental health, which includes suicide, other than their parents.
Right.
So because our youth are the front lines, we need to equip them with those skills necessary to know how to be there for one another. This, to me, is a way to augment the workforce that we've discussed today. If we simply depend on our clinical workforce to address the demand, especially with our youth, we will fail. We have to be more creative, more thoughtful, and most importantly, we have to have the youth at the table and with us as we design those solutions to work with them on ways that they can better help each other.
Thank you. Dr. Betlock, I want to move on with a question for you. We increased federal funding for home and community-based Medicaid services under the American Rescue Plan. This funding helps ensure that older adults and individuals with disabilities, including those with mental health conditions such as bipolar disorder and schizophrenia, can access mental health services outside of institutional settings. Can you, from your experience as director of the Arizona Medicaid program, speak to the important role that home and community-based mental health professionals play in delivering care for individuals who experience severe mental health disabilities? And what can we do in Congress to expand access to home and community-based care for those struggling with mental health conditions?
Senator, the investment that you made is really a once-in-a-generational investment in terms of where states are at and the ability to leverage that 10% home and community-based bump. And it's really broader, I think, than a lot of people appreciate. It's also on behavioral health services that states deliver through the rehab option as well. And those are incredibly important. So states are right now developing their plans. I'm working with a number of states, and they're generating their options that they want to invest in. So it's an exciting time for states, but states are feeling like there's a very significant time crunch here in terms of being able to establish this investment and do it in the right way. So I think those plans will be evolving, but there's clearly a unique opportunity, and these services are so important to be able to deliver services in the community to serve these populations. So it's an exciting time for states to have these resources, to be looking at workforce issues, to be looking at being able to deliver more services in the community.
Thank you, and thank you, Mr. Chair.
My colleague, Senator Warren.
Thank you, Mr. Chairman. COVID-19 is the worst public health crisis that our nation has tackled in over a century, but it doesn't exist in a vacuum. The pandemic has exacerbated every pre-existing public health problem facing our nation, and that is especially true for substance use disorder, which often co-occurs with other mental health conditions. Dr. Durham, I'm sure that you're familiar with the data. Did substance use disorder and drug overdoses increase or decrease during the pandemic?
Thank you, Senator Warren. They definitely increased during this pandemic. I think at DPH in Massachusetts recently, for Black Americans in particular, 69% increase over the pandemic.
69% increase?
Yes, in Massachusetts specifically. That could have been from various, this is usually fentanyl-laced substances. Many times cocaine use disorder is pretty prevalent in some of the Black patients that we see, specifically at BMC. And so we could think of lots of things that happened during this period. What happened to everyone happened also to the folks we see who have substance use disorders, job loss, economic insecurity, housing insecurity, the loss of social supports. Substance use disorders are a remitting and relapsing disease. People sort of think at one moment in time, you're sober, and then that's it, but it's not. And so it's a chronic medical condition, and we should treat it as such.
So let me just push on this a little bit and let that sink in a little bit, that we saw a 69% increase in opioid deaths in Massachusetts. We were already nationwide losing tens of thousands of Americans to drug overdoses. And the problem has only gotten worse. And I think this is where you were headed. It has gotten worse differently in different communities. So you were serving on the front lines of this pandemic at Boston Medical Center, which serves many low-income patients and communities of color. As the coronavirus spread through Massachusetts and substance use disorder worsened, what patterns did you see in terms of the types of patients you saw at BMC, the types of communities that were affected? Can you just say a little more about that? I think that's where you were headed.
Yeah, sure. Well, we predominantly serve about 70% Black and Latinx at BMC, people that identify as Black and Latinx, and about 30% don't speak English as their first language. Just like I think many people were scared to come into the hospital at the beginning of the pandemic. And so I think what happened, though, is that we got high acuity as we hit December and January, where people coming in with severe, whether that be mental illness, but also severe relapse in whatever substance that they may have been previously using and maybe had stopped. I think poverty and job loss, like I mentioned earlier, health, access to health care in general, there was a change in that, right? We've talked a lot about telehealth, but it doesn't work for everybody. And so this is the particular population where I don't think it worked well for. You needed to be on a Zoom link with your recovery coach. Did you have access to a computer and to get the Zoom link and then have a smartphone? So I'll pause there.
So this is very helpful. So you've told us about the scope of the problem. You've told us about how it hits different communities differentially. Let's talk a little bit about the solution. In recent years, Congress has taken some steps, like passing the SUPPORT Act, to expand access to addiction treatment services, but it's clear that more resources are needed. So let me ask you, Boston Medical Center is a national leader in addiction and substance use disorder treatment, research, and training. Would a significant federal investment in substance use disorder prevention help lower overall deaths, reduce these disparities, and help support providers like BMC?
Absolutely. I think that we need parity in mental health and substance use treatment. I think we also silo substance use disorders from mental health disorders from physical health. The more we can combine all of that, because it's one person that presents, the better we'll all be. I do think that we need to start early with community outreach and more investment in the community. I think when we speak about Black and Latinx communities in particular, we need more research that allows us to partner with community-based services to do some of that research, because we're not targeting that population well, and we need to invest dollars to do that.
Well, I really appreciate it. You know, we have an opportunity here not just to build back to where we were before the pandemic, but to drastically improve our public health infrastructure. I was very happy to see President Biden's commitment back as a candidate to invest $125 billion over 10 years in substance use disorder and the opioid crisis. And that's why in the coming weeks, I'll be reintroducing my Comprehensive Addiction Resources Emergency Act, or the CARE Act. This legislation would provide state and local governments the resources to combat substance use, to invest in biomedical research, in public health surveillance and professional training, and to expand access to naloxone. I am looking forward to working with my colleagues to get this done. I appreciate all the work that all of you are doing. I hope you can get better support from Washington to continue to do it. Thank you, Mr. Chairman.
Thank you, Senator Warren. And I believe what you and Dr. Durham have just done in terms of laying out this 69% increase in substance abuse in your state really conveys the urgency of what this committee has to do. So I thank you very much, and I thank you, Dr. Durham, because that's what this is all about. Senator Warren and I talk about this all the time. The committee's got a lot of stuff we got to deal with. We got all kinds of issues. But when you hear about a 69% increase in substance abuse, you say, this is something that can't wait. So I really thank you, Senator Warren. And I'm just going to wrap up with a couple of comments. And I want to thank our witnesses. Y'all have been terrific. And I think you have seen from the senators the very strong feelings about how important it is that we work on this and we do it coming together in a very polarized political environment. I don't know if any of you are aware of the Wyden story. My father wrote a book called Conquering Schizophrenia. It was about my late brother. And for years and years on end, my brother, who had schizophrenia, would be out on the streets in California, and the Wyden family went to bed at night worried that he was going to hurt himself or somebody else. And I think that's pretty typical of what families are facing when they're dealing with mental illness. And you all have described how many people fall between the cracks, the incredible stigma of this. Shante, thank you so much for describing what you're trying to do in rural Oregon, part of the state I love so much, to try to reduce the stigma. And you all have laid out a lot of solutions here. I mean, you've laid out a lot of solutions. And I've been talking with Senator Crapo. We think that this is an issue where the committee can come together and do better. We apparently reviewed the committee records. This is the second ever hearing of the Senate Finance Committee on the issue of mental health care in the whole over 100-year history. Senator Stabenow and Senator Daines are doing good work in the subcommittee, and I think now both Democrats and Republicans understand that we've got to bring a sense of urgency and commitment and resources into this issue so that mental health is really in line with physical health, which of course was the dream of Senators Wellstone and Domenici. And I think I touched on, I remember opening up the paper the next day and I said to myself, hallelujah, there's hope for Jeff Wyden and all the families who've suffered. And as you said very eloquently, Dr. Durham, in a lot of instances, the commitment to parity, in a lot of instances, is honored more in the breach than in the observance. So I thank you all very much for your excellent testimony, a great kickoff to this committee's work in this area. I think you heard from my Republican colleagues. They were raising important issues. I looked at the comments made by my Republican colleagues and my Democratic colleagues, and there wasn't an off-base idea in the House, today. Literally, you can go up and down both sides of the dais and see senators with great sincerity offering concrete ideas. So we're going to wrap up for today, but for all of you and your colleague who's out there on the web, I guess we're wrapping up for today, but make no mistake about it. We're going to be consulting with you. This is a to be continued discussion. Members know that questions have got to be produced, what we call QFRs, within a week. And I want to thank our witnesses again. And with that, the Senate Finance Committee is adjourned.
Thank you.